In this presentation, I'm going to review Addison's disease, or primary adrenal insufficiency, which is an entity that as endocrinologists we see frequently in clinic, but a fairly uncommon disease in the general population. When you think about Addison's disease, I want you to think about Bert and Ernie, and how Ernie appears to have the skin findings of a patient with Addison's disease. My goal of this presentation is to help providers identify by exam history a patient with Addison's disease, as well as understand the overall management. We will review adrenal cortex physiology, as this is the foundation for why we treat patients with steroids. I would like for you to be able to identify the signs and symptoms, as well as the presentation of an adrenal crisis. And finally, we will review how and why patients are treated. But first, let's differentiate between the primary gland and the secondary gland. The primary gland secretes the actual hormone whose effects we are discussing. For example, the thyroid gland is the primary organ when we discuss patients who have thyroid disease, as it secretes thyroid hormone. But in our case, the adrenals secrete cortisol, making it the primary organ. Our secondary organ is the pituitary, as it secretes ACTH, which stimulates the production of hormones from the adrenal gland. Here we have a cross-section of the adrenal gland. There are two main components, the inner part called the medulla that secretes catecholamines, and the cortex. We are going to focus on the cortex, which is divided into three sections. We have the zona glomerulosa that secretes mineralocorticoids, or hormones that affect the salt balance. We're going to continue to use the characters from Sesame Street, so you can see that Oscar the Grouch is a salty character. The zona fasciculata produces cortisol, or mineralocorticoids that affect blood glucoses. Clearly, Cookie Monster represents some hyperglycemia. Finally, the zona reticularis. This secretes androgens, or sex hormones. The Sesame Street representation gets a little bit dicey, but here's Cookie Monster representing the Incredible Hulk. Here we have all the enzymes and products of the steroid synthesis that happen in the adrenals, but fortunately, in the case of Addison's, I can simplify these pathways for you. We have cortisol as the starting molecule, and once it's taken into the cells of the adrenal cortex, we have three products. Aldosterone, our mineralocorticoid, cortisol, our glucocorticoid, and androgens such as DHEA. So what does aldosterone do? Here we have the nephron. Aldosterone works in the cells in the distal tubule and the collecting duct to increase the resorption of sodium and water, as well as cause potassium excretion. With the water and salt resorption, we have increased blood pressure support. So what does cortisol do? Most people think about it as just a stress hormone, but it does much more. In your liver, it promotes gluconeogenesis and increases the production of sugar to maintain euglycemia. It also causes lipolysis in fat cells, and in addition, it reduces inflammation, can suppress the immune system, and in the case of extreme production of cortisol, can lead to short stature and poor linear growth. So what do the sex hormones do? Mainly it's DHEA that's produced in the adrenals, which leads to axillary and pubic hair, but its byproducts, testosterone, DHT, and estradiol, help with secondary sex characteristics. In Addison's disease, we have a loss of function of the adrenal cortex, and this can be due to several disease processes. First of all, and the most common, is autoimmune. 21 hydroxylase antibodies attack the adrenal cortex, leading to the destruction of hormone-producing cells. In infiltrative infections such as tuberculosis used to be the most common cause of primary adrenal insufficiency. Here you can see the caseating granulomas filling up the adrenal gland in the picture below. The third cause of primary adrenal insufficiency is thrombosis or hemorrhage, typically seen in disseminated intravascular coagulation. Here on the left, you have the gross representation of a bilateral adrenal hemorrhage associated with meningococcemia. You also have purpura in the lower extremities, which can be an outward sign that this is happening to your adrenal glands. There are many other causes, but those are the main three that we will focus on today. So now that we have a destruction of the adrenal cortex, we end up having no production of aldosterone, cortisol, or DHEA. So in the absence of these hormones, we have physical findings of Addison's disease. With aldosterone, since it helps with maintaining blood pressure, patients can be hypotensive during examination. In addition, they're not effectively reabsorbing sodium in the nephron. This leads to excessive salt craving. They will also have elevated potassium levels due to the inability to secrete potassium in the nephrons. Some of the main symptoms of cortisol deficiency include fatigue and weakness, represented by Ernie here going to bed. However, abdominal pain and anorexia can also be present. More importantly, patients can have hypoglycemia. Here we have Cookie Monster thinking about cookies and likely becoming hypoglycemic. With hypoglycemia, you have the symptoms of sweaty, weakness. You can act funny like Dopey here. You can become very sleepy, and like most of us, you become grumpy and irritable. We also have hyperpigmentation, which is like an unhealthy tan all over the body, including the mucosal membranes. The hyperpigmentation can be explained by the loss of cortisol feedback loop. ACTH is derived from POMC and is broken down into various hormones, including melanocyte-stimulating hormone. When the feedback loop is working, there is no imbalance in the hormone levels, and the adrenal glands are happy. When the adrenal glands are no longer functioning, we have loss of cortisol levels and the loss of the inability to inhibit the production of POMC and ACTH. And thereby we get an increased production of ACTH and melanocyte-stimulating hormone. It is the excess of MSH that causes a hyperpigmentation in our Addison's patients. Finally, with the loss of the sex steroids, some girls can have irregular periods and have decrease in axillary and pubic hair development. Finally, something as we as pediatricians don't frequently talk about, there is decreased libido. So here's our black box libido warning. Adult patients with Addison's disease do complain of this finding. So how do we diagnose a patient with Addison's disease? It is commonly made by a very low morning cortisol level associated with elevated ACTH levels. If it is autoimmune, there will be an antibody called 21-hydroxylase, which can be detected in the serum. Along with the low cortisol, we will also administer cosentropin, which is manufactured ACTH, and monitor the response by the adrenals. We use a large amount, 250 micrograms of cosentropin, which is large enough to saturate all the available receptors. And in a patient with a normal adrenal function, you will see a robust cortisol level at 30 and 60 minutes. In patients with Addison's, the cortisol will not respond to cosentropin. An adrenal crisis is a sudden and severe adrenal insufficiency, which can happen at diagnosis, times of stress, or at times of poor compliance. This is a medical emergency, and patients will have low blood pressures, hypoglycemia, hyponatremia, hyperkalemia from their glucocorticoid and mineralocorticoid deficiencies. The foundation for treatment revolves around the rapid administration and a large amount of steroids. You'll want to select a steroid that has both mineralocorticoid and glucocorticoid effects, and hydrocortisone is the most commonly used medication. In addition, you will need fluid resuscitation and glucose administration as the mainstays of therapy. Once your adrenal crisis has been treated, the primary diagnosis of adrenal deficiency has been made, patients will be on lifelong medications to prevent further crises. This includes fludrocortisone, which is a potent mineralocorticoid, which replaces your aldosterone needs, and hydrocortisone, or prednisone once growth has completed, which will replace your cortisol needs. In summary, remember the signs and symptoms of adrenal insufficiency, which includes hyperpigmentation, salt craving, weakness, fatigue, hypoglycemia, and low blood pressures. And remember that crisis is a medical emergency. Treatment with steroids is pertinent, and you will need fluid and dextrose support in addition. And these patients will require lifelong chronic mineralocorticoid and glucocorticoid replacement. Thank you.